So we talk a lot about how reflux disease is a spectrum. You might have heartburn only if you eat chocolates. You might have heartburn only if you eat lasagna. You might have heartburn only if you have lasagna with your wine, okay? And in those cases, we use simple over-the-counter medications, usually antacids. Sometimes you might take an H2 antagonist 30 minutes before a meal. Then there are patients that require a proton pump inhibitor. It's a step up to cure the esophagitis, and once it's cured, they get off the medicine. But then when you start treating patients over the long term, and by long term I mean get into twice a day use of PPIs, at least 6 months of medical therapy, those are the patients then we start looking at what is the anatomy. If the anatomy is not normal, then those are candidates for TIF, particularly if we're just dealing with heartburn. The next step on the spectrum is then regurgitation. If they start having regurgitation, it's likely they have a hiatal hernia. If you can document a hiatal hernia on retroflex endoscopy that's at least 3 centimeters in diameter, then those are the patients that need a hiatal repair before they get a TIF in order to get good outcomes. And our pH studies show that if the TIF is intact without a hiatal defect, or if you have the hiatal opening controlled by a hiatal hernia repair and the TIF is intact, those patients are going to normalize their pH score.